is Sinead Walsh, and Sinead was spent 5 years as the ambassador of Ireland to Sierra Leone and Liberia, and as the head of Irish Aid. And she spent 10 years in the NGO sector in South Sudan, India, Pakistan, and Rwanda. Working with Concern Worldwide on governance and the capacity building of local institutions. She has a PhD in social policy from the London School of Economics, and her doctoral thesis was on the improbability of the accountability of NGOs to their intended beneficiaries, the case of aid action. She also...
Which is available. I mean, it's not just a dissertation.
Google.
You can get it. You can get a book.
Oh, it's a book now. Okay.
No, it's not.
And
It's not a book, but you can Google it and it's free. It's a PDF.
and we've just determined that since I'm really bad at keeping people to their time, I'm not going to be responsible for time, and Sinead is actually going to take over and run the session. So to Sinead.
And I'm very strict, so we really do need to be thoughtful about the people who haven't presented yet. So I really want us to try to keep this discussion to 20 minutes. I think that the presentations have been terrific. I'm just going to make a couple of remarks and pose a couple of questions before opening the floor. As Salman said, I've discovered I have four hats to be here. One is the PhD and obviously the Ebola connection. Another is that I spent those 5 years chairing the Liberia Health Sector Pool Fund, which was an absolute nightmare, to be honest. But it is an example of UHC, so I'm going to come back to that. But a very, very challenging situation. But also, and I don't know if I've gotten around to mentioning this to most people, but my new job, still with the Irish government, is actually in the multilateral unit focusing on the UN and the World Bank. So I'm finding this this conference just... It's almost like Erin and colleagues designed it, just really for my information and education. So it's really terrific. I just wanted to just note a couple of maybe themes that have come from both of the papers and the presentations. I mean, I think everybody in this room can pick up a very strong theme around ideology, and I think it's something that Jean mentions and his colleagues in their paper, is that Ebola wasn't actually a failure of the system. This is actually how the humanitarian system and the global health system has been designed to function. So we might think of Ebola as being a failure, but actually coming back to the point that Roger made yesterday when you talked about some human rights initiative that you said, oh, it failed, but I mean, it succeeded in all the ways that we got the money and we got the media and I think Ebola succeeded for many people and many organizations and just failed tens of thousands of people in the three countries. And so fundamentally, I think we can all see that both the UHC and the Ebola papers are looking at how in the end of the day, we fundamentally just don't value poor people's lives, I think is the commonality, whether it's in terms of general healthcare or in the Ebola outbreak. I think there's just three levels that we might want to reflect on in the discussion. At the community level, one theme I think that unites the Ebola paper and the UHC paper is that actually a huge disincentive in Sierra Leone for people to show up to Ebola treatment centers is that if they didn't have Ebola, but they had malaria or they had typhoid or whatever, well, they were just sent home most of the time, right? Because there isn't universal healthcare, although there is free healthcare for some groups in Sierra Leone, but pretty much anybody else. And this is something that communities, people in communities said to me when we were going around and sort of chatting to people and be saying, why are people so reluctant to go to ETUs? And they would say, well, for us, it's like Ebola, it's just one of so many things that can happen in a country with such huge health problems. And the fact that all these people telling us to go to ETUs don't actually care if our children have, diarrhea, it makes us not trust them, and it makes us think they have some kind of ulterior motive. Why are they only interested in Ebola? Why aren't they interested in our health and in our lives as a whole. And I think when we talk about accountability, trust is really such a key issue. And the fact that governments were, particularly the Sierra Leone government, actually were quarantining people en masse, was another very big kind of trust issue. So lots of issues there at the community level. At the national level, I think Rob has talked a good bit about the government level. I think it is a little bit dangerous, though, to not reflect on some of the ways in which the national governments also failed on Ebola. The international community absolutely failed, and I would say failed even more, given that the national governments, couldn't have been expected to deal with it all by themselves. But if you look at differences between the countries, you can definitely see that some that national governments also have had they also failed their populations, and I think we need to address that, particularly when we're talking about UHC. The policy is not going to be enough. We are going to have huge quality issues. I'm sure Rob just hasn't had time to talk about that yet, but obviously huge quality issues. But just I wanted to then just start challenging people also to, that we talk about solutions in this session. And I think, Mara, you might have mentioned this. All of these governments are members of these UN bodies, and they're members of the World Bank. And last week when I was at the UNFPA board meeting, one African country, which I won't name just because of the camera, but I'll name to people later, basically, held up the decision on UNFPA's 5-year strategic plan for 5 days. So it was 5 days of negotiation because of the objection of one African country, which was mainly more to do with they didn't really want UNFPA to be doing family planning. I don't want to make it sound, I don't agree with them, so I don't want to make it sound like they're a hero, but the point is they could do that because they were a member just like anybody else. And sometimes we forget that and we think, only the donor countries have the power, which, to be fair, is largely often the case. But actually the governance mechanisms of these organizations can also be used. And this may have been you, Mara, who raised this, but it's also about thinking about those sorts of tactics. And I'm curious if any of you have come across that. But just finally, I wanted to just come back to Faisal Uncle, really, not Uncle Faisal, if you ask me. Faisal Uncle was saying earlier in terms of converting the enemy, right? So a lot of people have talked a lot about external mechanisms and lawsuits and so on, which, community mobilization, for all these issues, and I couldn't agree more. But as a bureaucrat myself, working for, a donor agency, I'm very interested in this notion of how you sort of change the hearts and minds of people working within these agencies, outside of the option where you force them to change because of some external mechanism. And Paul and I were just discussing, I think all of us in this room would have friends in places like WHO and the World Bank. Some of us have done, consultancies for them or, do them on a regular basis. I think all of us would agree there's lots of really good people and sincere people and people just like us in those agencies. So how do we do a better job of, and I'd love if people on the panel, but also people in the room more broadly, might have some examples of where they have actually managed to influence in that sort of non-confrontational way, the attitudes on some of these issues of people working in those big bureaucracies. Or, some of you might say, sorry, I've given up. I tried and it didn't work and I've given up. So, but I would just to try to move us a little bit more towards, solutions. I would just be interested if people could talk a little bit about strategies and tactics on the non or the less kind of controversial side of trying to influence bureaucracies. So maybe I could just start with the should I get it? Maybe let me actually, just for the sake of time, let me get a couple of questions and then we'll go to the panel with my question and your own questions. Randall, please.
Two sort of observations, and one is that after the discussion, Rob, and the user fees, just a sort of reminder that removing user fees is not a panacea if you don't invest in health systems. because basically people are going into the hospitals and then having to go out and buy bandages and everything else they need. So it's like a user fee. Yes, they discourage people from attending, but it doesn't really, it's not a panacea. And the other one was just Sinead's comment, just offhand. She says national countries couldn't have been expected to handle it on their own. We can't let that sit as unproblematic. It should never have been the
Absolutely.
situation to begin with. If it wasn't for the failure of development and not investing in health services, but only investing in things you can sort of shoot in people's arms, we wouldn't be able to sort of just say that.
Absolutely. Yeah. Is there another question? Let's go to James.
Yeah, just really briefly, I think it's important to just remember the Berg report, which I don't know how many of the historians remember that report, which came out in 1981 and was sort of the blueprint for structural adjustment. And one of the justifications for user fees was that in Africa was that Africans already spend money on traditional healing and ceremonies and all this stuff. Therefore, they have a willingness to pay. And it got cited over and over and over as like a fact. And it just made me think, you know, in terms of Rob's presentation, you know, it's sort of like, are you going to believe me or your own eyes? You know, here's this obvious thing that is crazy, and yet this evidence is marshaled. And as an anthropologist, I take great offense at the fact that they were saying that they pay for traditional healers, therefore they pay user fees. I just thought it's important that the Berg report is one of the original crimes around this, I think.
Great.
But I think it raises more broadly accountability around science and evidence, you know. What do we do with that question? And so just wanted to throw that out there.
I'm just going to take Roger's question, and then we'll go to the panel.
It's very similar in a follow-up, but yeah, I would say, I would say having most of my work in law and politics, we expect ideological fights. And listening in, you know, all of these medical professionals and researchers in this field, one would not expect to see the exact same stuff. So I was talking the Iraq War. It was just phony facts, just weapons of mass destruction. Saddam and Osama bin Laden are I mean, for those who know it, it was false, phony, ridiculous research, like garbage in, garbage out. And one would think, and obviously it's not true, and I wonder why, that in a field where research is the basis, why can't facts and research in this area have more of an impact on policy? I guess it's kind of a question. And as solutions, we're talking about change mindsets. I mean, I come across that all the time, and it's people always say that because it's true. But it's also like, wow, change mindsets, 30 years of education for the next generation? Or, yeah, I mean, it's persuasion in that sense. You're not going to win militarily. It's persuasion, but on our side is facts and research. So why can't that, or how can that, advance into policy, especially in an area where it clearly should? You know, in law and politics, fine, we have our different views. We have our different ideologies. And it seems that it was ideology that's behind user fees, just ideology.
Absolutely.
So,
Yeah. Great. So let's just go to the panel, and then we'll come back for another round of questions. Paul, you wanted to start?
Well, you know, I just want to say that just to use a kind of a framework from medicine again, and you know that these are tragedies that are underpinned by ideology and pushing it forward. I think really we don't need more evidence, right? And you know, Marcos yesterday, you know, just laid out in a non-plaintive tone the history. I mean, this is the colonial empire reluctant to cede power to build something. Randy, you know, in shorthand, he just is talking about, you know, the healthcare for you is a smallpox vaccine that may or may not work because it may not be heat stable, et cetera. And one of the questions of accountability that I would like to echo, again, Randy, James, and you just now is that in order for this to work again and again and again, right, if it is a success, that is to make something that's clearly going to fail for poor people good for others and then define that as a success. It does require complicity from academics and science, right? I mean, you know, the people who we're talking about who are our friends, they also have MDs, MPHs, PhDs from the same institutions, Harvard, Johns Hopkins, especially. And I guess what I'm saying is it's so important to look at the specificity of history. I mean, I'm and also to go to medicine, which says, okay, what's the diagnosis? What's the history of the present illness? What are the lab data that we have? What is your clinical impression and what's the prognosis? Because you want us to get to prognosis, that is, what are we going to do about it? What's the treatment plan? The treatment plan and prognosis are different. But whether you look at, you know, pneumococcal disease, you know, whether you look at pneumococcal disease or influenza in 1918 or Ebola in 1976 to 2014 or Marburg in 1967 or drug-resistant tuberculosis, which began, of course, as soon as the mycobacterium was challenged with the drug, right? It all, you know, the diagnosis is pretty much the same, right? It's that we're deploring setting the standards lower for poor people. And another way of putting it is we have low aspirations on behalf of others. Not on behalf of ourselves. We would never tolerate, you know, isoniazid monotherapy for active tuberculosis as a recommendation published in the New England Journal of Medicine, which, as you point out, should be free of ideology when possible. And historians will say, well, it never is. But boy, that's an extreme example. And all of these examples are extreme. And having lived through many of them, and I would be happy to call myself an AIDS activist or a cholera activist, well, not on behalf of the bacterium and mycobacterium and virus, but having been at this for all of my adult life, you know, I just can't think of any example that isn't really about that, having lowered aspirations on behalf of others who happen to always be poor people, brown people, black people. And that requires complicity of course, powerful institutions. That and the point that Jean and our team was trying to make about Ebola was, first of all, it's inside this room with the fellow academics, right? And anthropologists happen to be physician anthropologists who happen to have been involved directly as clinicians in, you know, responding to, again, all of those afflictions that we mentioned and many others beyond Ebola, AIDS, drug-resistant TB, and cholera. You know, when are we going to turn our attention as anthropologists to the tribe that must be complicit, you know, if we can have policies like the ones that Rob has described, you know, again and again. So that's the diagnosis, right? Now, and I'm not going to, the history of president illness has already been given by real bona fide historians and by other kinds of social scientists. So the prognosis, you know, maybe it's great if you want to be a professional consultant, you know, you have a good prognosis if you know, and the treatment plan, it has, if we can't have a treatment plan that's focused on people who are subject to, you know, to repeated injury. I mean, and when I say people, I'm talking about generation after generation after generation. You know, I think it's okay to say, well, we've tried and failed, but it's not okay to say, so we give up, right? Because there's so many ways to intervene, direct service delivery to remediate injury and harm, you know, but I don't know if it'll come up from Brian or others, but just to get, you know, just to get a cholera vaccine, you know, used in the middle of the world's largest epidemic that we were paying for, meaning not the epidemic, but the cholera vaccine. We weren't asking, you know, for our colleagues in these bureaucracies to buy the vaccine. We were saying, we're going to buy it, right? And even that was just a nightmare, right? So, and it was the same story, as I'm sure Salman said. He said a little bit yesterday, but I'm sure he did today. We weren't saying, hey, you buy us these quote unquote expensive second line or third line drugs. We're saying, okay, we'll do that. And by the way, maybe I missed this, but again, how could we not have professional complicity when you look at these documents, as Aaron and Rob have, and find out they have absolutely no evidence, not a shred, to support these claims, whereas we have masses and mountains of evidence, right, to support a contrary view, which happens also to be a social justice view. So it's not about another study, although we like doing that. It's not about another consultancy to see, well, how international institutions failed. It's really, how do we link, our fairly robust analyses of the problems that we're discussing to an action plan that makes a difference in people's lives. And that means, a material intervention. And that could be clean water, but to divorce accountability, to divorce any endeavor from that project of basic social and economic rights for the shafted is going to, again, be a form of complicity. And now, again, I know I'm speechifying, I'm saying that's just something I hope that we can do, right? Because of course removing user fees is not going to be a panacea. I mean, all you have to do is go in and see that there's no staff, space, or system able to deliver a service, so you remove the fee. You could actually be harming people by inviting them into dangerous places, which is the point that Jean was making. So anyway, I just I'm begging us to keep going back to your challenge to how do we change it, because it's clearly not about marshaling better data, as Randy, when Randy put that slide up, and I'm done with this, when Randy put that slide up, some people chuckled, right? But I felt like a dagger was driven into my heart, because it's not a joke.
No, it's
and
spot on.
It's not that the people who chuckled, they chuckled ruefully. That's not a complaint, but I'm saying this is very much the situation that we're living in right now. And that's why I was saying, Rob, please show us some reason for optimism that the policy change will make any difference without implementation. Love, Paul.
And Rob.
Yeah. Well, thanks. I suppose to answer Roger's question, and it's very relevant to what Paul was saying, I think it is all really about politics and political activism now. I mean, I think, this situation where fake evidence, sort of makes it into the newspapers and is presented as the solution, is really around political interest groups. I've got a great slide from the Daily Telegraph in the UK slagging off the NHS. Britain can no longer afford the NHS. It's falling apart. The services are rubbish, which we know, the users of the NHS know is not true. It's just a thumping big lie. And then there's an ad down this side saying, oh, buy the Daily Telegraph health insurance scheme. And you can just see, sort of how the interest groups, which will be around. One mustn't forget that there are many interest groups that benefit from user fees. A lot of the medical profession, the pharmaceutical industry, the insurance companies, but also the middle classes. It suits them to have a system that keeps the proletariat out and, enables them to sort of, get to the front of the queue and get free healthcare. And really, the way to tackle that is just to dismiss this propaganda that's put out by the other side and demand of politicians that they get rid of the fees. Well, they replace the fees. You make a very good point, Ranulph, that it's not around just abolishing the fees and everything will be fine. And in fact, the language, I think, has very much changed now. And this is why I'm a huge fan of the universal health coverage movement, because it really is around replacing useless financing mechanisms. Private insurance is useless as well. Let's call it for what it is. And also user fees with compulsory public financing. Now, ironically, one of the best papers that describes the transition to universal health coverage and the the financing reforms was produced by Results for Development, the institute set up by David DeFranti. It's a wonderful publication that sort of shows that as countries get richer, they spend more money on health because that's what societies want. But also, there's a dramatic shift away from private financing to public financing. And that is explicitly driven by politics. And the masses saying, it's just unacceptable that poor people die in the street and rich people live. And really, that's what we've got to be fomenting, I think, really, to have political leaders recognizing it's in their political interests to satisfy the population and mobilizing the population to demand that. We've seen some dramatic examples of that. For example, in China, that had the system of the barefoot doctors and free primary health care, then made the mistake of being sort of wowed by the American economic model and started to introduce private financing. The doctors then started selling medicines. Now, that led to increased drug-resistant TB and all these sort of the ills of a privately financed system. But what really brought about change in China was when doctors were being killed, where the hospital, I'm not advocating this, don't worry, Paul, the hospitals were being burnt to the ground, and the Communist Party were thinking, whoa, what's going on here? And they recognized that to stay in power, they needed to sort this out. So I'm very much thinking that universal health coverage is about public financing, and that's delivered through political activism.
Aaron, anything to add to that?
Three points. One, I think, as Rob was talking, I'm coming back to, as everybody seems to be, to Faisal's lecture this morning. And it's this question of data. You were saying that it's all about politics. That that in fact, what's driving the Berg report, what's driving the obfuscating character of the evidence, the phony evidence, the fake evidence that's being brought to the fore is politics. But in a way, I think what's driving it is exactly the kind of anti-politics that that you were addressing this morning. An ideology that there is no politics as long as you present it in terms of data. That if you present it in terms of data, you're protected somehow from, because of the norms and fashions of academia, that means that every 10 years or so, the data that you present have to be couched in the context of a different academic fad. So whereas decentralization was legitimated in 1972 by McKinsey in terms of modernization theory, exactly the same principle is mandated by WHO at Alma-Ata in the framework of empowerment of communities, and exactly the same principle is mandated 10 years later in terms of neoliberalism. It's exactly the same intervention, and it's just as damaging. Jean showed you showed that picture of the mine in
Ghana.
yeah. The reason that health systems were decentralized in Sierra Leone, you I'm sure know more about this than I do, but based on our reading, after 2002 with the Local Government Act in Sierra Leone in 2004, it was clearly driven by the mining interests. They wanted to decentralize, to remove the authority of other agencies besides the chiefdoms, to intervene in the arrangements that they were making with these elite families. The health system, the decentralization of the health system, which was so damaging, removing the meso level. There was an anthropology paper about this, a kind of a post-mortem on the epidemic. One of the major problems was that there was no coordination because the system had been so decentralized. But the motivation for that was, a kind of legitimation of decentralization in the latest fashion, the poverty reduction strategy papers. So, it's cover. There's this cover, and one of the reasons that these phenomena that are so, that are covering, blanketing such suffering are so impenetrable is this ideology. And so I think that, your observation is important, but it also, I think, demands a reckoning about the way that we do business and the way that we, engage with each other as objective academics, in ways that are very congruent with. One more thing that I wanted to say directly to this point, the Berg report was a story. It was not the data. The data came from, surveys in West Africa from the 1970s, and the Philippines, principally, one of the was one of the sources of this data, that academics at the University of Michigan, at Michigan State University, at a Sierra Leonean university had done. They did these household surveys. These household surveys said, well, people aren't getting any health care because we're in the middle of an oil shock. They're paying all this money, so we can charge them for care. And this became the basis for the programs that were put into place during Alma Ata. So, the story that's being told and the cover that's being given to it, I think is a product, in really significant measure of academic norms, not of like World Bank norms.
Right.
And we need to reckon with that.
Right. Now we are going to have to.
All right.
No, and I think that was great. And I know Jean hasn't had a chance to talk, and I know there's more questions. So I'm going to ask you to save them and then pretend, bring them into the next session and pretend they're linked to the next session. Or cocktail reception. But thanks to all the authors very much. Excellent papers.